Hello and welcome to the Healthcare Today podcast. Our guest today is Anshumen Bhagat, NHS GP Principal and Chief Medical Officer at private healthcare provider GPDQ. With more than 20 years of experience, Dr. Bhagat is renowned for his outstanding contributions to the medical field, specifically his dedicated work to reduce NHS waiting lists through the use of digital technology. Today we're talking about how mental health is central to successful health systems and how burnout is the silent emergency behind the workforce crisis. You've previously stated that the primary care workforce crisis is getting worse because the way we ask clinicians to care has become psychologically unsustainable. Why do you think this psychological dimension has been overlooked for so long?
It's such a huge topic to unpick. And, I'm a GP of 21 years now. I became a doctor 25 years ago. Seeing that sort of healthcare landscape change, not just from the demand on the health service, but actually how are clinicians coping. I kind of grew up as a doctor in a time when there was very much an attitude of crack on. You've got to just, keep on going. You chose this career. Nobody said being a junior doctor was going to be easy, and nobody said delivering healthcare was going to be easy. And so we probably brought up with a bit more resilience. However, I'm not sure how welcomed that resilience was. And as we teach new GPs, we train undergraduates, I'm afraid the newer generation doctors are probably, and quite rightly, not dealing with the same workforce that I did. And similarly, I suppose I'm not dealing with the same as they did. Look, I think you've got to think about how the NHS actually measures success, if you want to call it that. And it's often measured by activity and outcome. But the concept of emotional load is just, again, one of those get on with it. We account, for sort of appointments, referrals, targets, waiting lists, but we rarely measure sort of the cognitive burden of making, quite frankly, hundreds of complex decisions every week. I think we just need to understand that we're delivering with fewer clinicians, although, there'll always be a debate about, well, we're training more doctors and training more clinicians. Yeah, I hear that. But actually on the ground, I'm afraid the current NHS setup is really built to probably serve about 35 million people, not 70. So, and that's where some of the psychological dimensions are starting to open up. At least we talk more. We accept that it exists. That was one of our first battles. Can we at least say that it does exist? Because if you don't acknowledge its existence, you're not really here to find a solution for it.
A 2024 NHS staff surveys showed that 41% of staff reported being unwell due to work-related stress. Now, that's a staggering figure. When you hear that number, what goes through your mind as both a practicing GP and a leader?
I'm not sure it's 41% is probably my first call. I'd probably say 41% means that you've probably actually had to take time off work. I reckon the figure is probably closer to 85% in terms of people that are actually suffering in silence. It's really difficult for a clinician to go off sick. For a clinician to say, I've reached to such an extent where I can't go to work, there has been years prior to that of build up. Warning markers would have happened way before that. So I think we've normalized something that should really deeply alarm us. If over 40% of NHS staff say that working related stress has made them unwell, then it's no longer simply just a well-being issue. It really truly becomes an operational and a patient safety issue. That's really where I've spent a lot of my career trying to focus on. I'll give you a real example. About 15 years ago, a colleague of mine and friend committed suicide up in Scotland and as a GP. And I really thought at that point that firstly, you have to get over what's just happened. And sure, as a fellow GP, my head went straight to, well, it must be your job that's done this. And you start waiting for the press to talk about it. You're expecting local GP groups to reflect on this and talk about it. And not one thing was talked about. And really, you suddenly realize you're literally just another statistic. I don't want this to take away from suicide in general. It's one of my, I suppose, main job descriptions really is, we don't want anyone to kill themselves. But I do know that the healthcare sector has such a high stress rate. And so really that took me on a journey to truly understand how big this problem is. Well, if I didn't hear about it, then certainly a GP that doesn't know him is never going to hear about this. And so how big is this problem? This is just the fact that it's landed on my door, or meaning my environment, my friendship circle, the fact that it's landed there made me really want to delve into how big this problem is. And you suddenly realize that you've got 6 to 8 doctors a month killing themselves. And we still don't talk about it. And when I started GPDQ, it was really built on a premise of two fronts, really, in the sense that, yes, we wanted to build a great primary care service, but the other half of it, it was built for resilience and burnout for my colleagues. It was built that, well, if the NHS is the only option of employment for you, where you have to work in a GP surgery, in prison, or in out of hours, and those were the only options you had, and if you don't want to do those, you're not going to be able to pay your mortgage, then we do have a problem. And that was where I started to really think about what other things can you do with us. I certainly don't want that to come across that we were taking GPs away, because I think the NHS was probably doing a fantastic job by itself, really. We wouldn't take clinicians that would leave the NHS. I'm a lover of the NHS. I will never leave it. But my relationship with it is like an ill relative. I can't leave them. I will continue to fight for something that I truly do believe in.
You've said that mental health should be viewed as a core infrastructure alongside estates and digital systems. Now, that's a bold framing, traditionally speaking. If a health secretary or an NHS leader fully embraced that idea, what would tangibly change in how they allocate resources or design services?
I think we've got to probably look at this in two ways, and it kind of neatly leads on from my last comment. If we really do not take or acknowledge, yes, we've been acknowledging it for years. The question now is, well, what is the solution? And, if our health secretary was to ever listen to this, and it really comes from a true passion and love for the NHS, but we have to understand the limitations, because what we've got is, in reality, a wonderful concept: free healthcare at the point of need. I don't think anyone can argue that. But I would compare our NHS to a five-star hotel that was built in 1990 and hasn't been touched since then. Now, whilst it was fantastic in 1990, things have changed. Technology's moved on, and we are moving forward in many different ways. But the reality is that whilst the budget grows, the population is rising, infrastructure needs investment, technology, we're doing some great things as well, which I think are definitely going to help move things along. But the reality is, we're not going to replace humans. You can't replace an A&E consultant or an A&E doctor. You can't really replace a GP partner. We are truly the backstop for everything. And this is nothing against my salaried GP colleagues, but the responsibility that we take as a population. I come from 3 generations of doctors, both sides of my family. And I've seen general practice from my grandfather's days and my father's days. And when you see the general practice that I truly wanted to deliver, it's about being a part of the community. I walk down the high street and you meet all of your patients along the way. I get it. Some people really don't like that. But this, for me, was what true general practice was about. So when we talk about core infrastructure, I think we would start designing services around human sustainability rather than simply kind of squeezing more and more out of an existing workforce. And I think that's one of the biggest feedback that we get. And even if I comment on what we're doing in primary care, everything, let me just give you a statistic. 90% of all doctor-patient interactions in the United Kingdom happen in primary care. However, we receive 10% of the budget. Now, you soon get to understand that if you do not invest in primary care, everything downstream becomes hugely problematic. So whilst we're trying to save money, we're trying to reduce referrals, I get it. But the reality is that unless you start investing truly into primary care, into sustainable primary care, and I'm not just saying this is not just money. Money, absolutely. What does money buy us? It buys us clinical staff. But ultimately, if you're not looking after the clinical staff, well, where are the clinical staff? When I started in primary care, it was me as a GP and my practice nurse. Those are the only 2 modalities in a GP surgery. And if your nurse couldn't deal with it, well, I'm dealing with it, meaning from a clinical capability perspective. I think we can all remember when Jeremy Hunt had said back in 2015, I believe, that we needed 5,000 new GPs by 2020. We got to 2020, and I think we probably needed 9,000. The answer to this huge GP shortage was actually to introduce a completely different workforce, and funding followed massively into powering ANPs, which are advanced nurse practitioners, EPs, which is for sort of specialist clinical practitioners in specific areas such as mental health and MSK. And nurses started to become prescribers en masse. And what you started to realize was that it's absolutely right. You know, it really is about the right patient seeing the right clinician for their problem. Does a GP need to repeatedly keep seeing sore throats all day? Or can you get an equally qualified, and even the pharmacy team? So I think things are moving in the right direction, but sadly, what that then left was a whole GP workforce without jobs. Now, last year, you know, at GPDQ, we have probably, 800, 900 clinicians working with us across the UK in terms of our staff mix. I had GPs without jobs. And I just couldn't believe that we were actually ending up in this scenario. Didn't we need 10,000 a while ago? And literally now I've got GPs very upset because they haven't got a job and they can't get a job. They can't pay their mortgage. I mean, things are again changing again now. I'd say, just to get more to the sort of core of, well, how would we start to make sort of tangible change to you need protected admin time. I think you'd need to make that standard. I think to see, I don't know if anyone has, we've all sort of accustomed ourselves that 10 minutes is a sufficient amount of time to see a patient. If you've got an itchy ear or a dry bit of skin, 10 minutes is fantastic. But if you're 85 with multiple comorbidities, social care problems, mental health problems, physical problems, it takes 6 minutes to get into the surgery and sit in your chair. You know, 10 minutes isn't enough. And so we really have to start to think about, well, what do you want us GPs to be doing? GPs should be looking after more complex cases. But the reality is you need the admin time. You need flexible working. It has to be embedded into workforce planning. There are more female GPs in the UK than male GPs. Yet we want our female GPs to be mothers and do all of those things as well as be full-time GPs. Well, I think we need to introduce flexibility into working times, psychological support and debriefing after difficult cases. We need to make these things normal. And these are the things that we've implemented in our own surgery, where we'll have a coffee break mid-morning. And if you don't really talk about clinical cases, it becomes a nice little chat, but it actually just brings you out of your clinical environment for a bit. We invest heavily in states and scanners and digital systems, and quite rightly so, but the workforce itself is probably the most important infrastructure that the NHS has. I think we are the second or maybe third largest employer on the planet. That might have changed now, but certainly we're a big employer. Look, the reality is that without healthy clinicians, the rest is simply expensive equipment.
With GPDQ, you've been careful to say that the goal isn't to pull clinicians away from the NHS, but to support portfolio careers. For a GP who's burnt out in the NHS, what does a healthy portfolio career actually look and feel like?
I think I'm going to start by saying nobody becomes a doctor to become a millionaire. There are easy ways of doing that. We've had to get the right GCSE grades. You've had to get pretty much straight A's in your A levels. You've got to then do a 6-year grueling degree. Then you have another 6 years postgrad minimum of possibly more exam. And we still continue to learn. I say all of that because, and that wasn't for any sort of violin moment, that this is really just to stipulate that I want people to understand we do this truly because the age-old medical school interview, why do you want to be a doctor? Because I want to save lives. That's the reality of it. You want to care for people. You want to help people. So for a clinician to get to a point where they are now thinking about leaving the country, leaving the NHS, signed off work, getting depressed, God forbid, killing themselves, if before one gets to that point, we have to have alternative solutions. And that was literally one of the main drivers of why GPDQ exists. It means staying in medicine without actually being consumed by one single model of work. And you'll think, well, everyone else does one job and seems to be happy with it. Why do GPs suddenly need varied portfolio work? The reality is, I think we forget sometimes the decisions that we have to make at pace. It's not simply fair, it's not sustainable, and it's not safe. The reality is that there's no one to complain to. GPs are doing admin in their own time at 8, 9 p.m. at night, just to catch up. You're constantly thinking, God, did I write enough in that consultation? Should I have ordered this? Should I have done that? These second-guessing decisions truly happen because you're not given the correct amount of time to process decisions. I wouldn't want people to think, well, we're just dishing out antibiotics. Okay, that's one element of it. But there are complex decisions being made. Ultimately, a GP sort of may combine NHS sessions with digital care, urgent care, governance. It doesn't have to mean leaving seeing patients. It's about just working in a slightly different environment. Governance, education, leadership, diagnostics, private sector, it's all there for the grab. And the reality is, and I will reiterate, I am absolutely clear. If you leave the NHS, you can't work for us. The reality for me is quite simple. I want to be a part of the solution here, not a part of the problem. My main outtake was that we need to feel refreshed. Doing the same high risk activity again and again is one of the biggest causes of burnout. So I think, having a day doing some commissioning or doing some more educational stuff, it really just kind of changes the landscape. Done properly, it keeps clinicians mentally fresher, professionally engaged, and quite frankly, financially sustainable.
You describe private and hybrid models as potential innovation testbeds. By that, places to pilot new ways of working that the NHS, by its very nature, struggles to experiment with. What's one innovation that you've seen or implemented that you would love to see adopted more widely across the NHS?
This relationship, the NHS and the private sector, this has been an age-old friction point. As somebody who started my career in the NHS, I started private practice even before the CQC began. And so it was really, when I started private general practice, it was a dirty word. A lot of my colleagues were, and by the way, private general practice didn't really exist. It was, I'm going to just call it the Harley Street phenomenon. Oh, yes, I'll go and see a doctor in Harley Street. And it was kind of that view of things. Everyone was very comfortable going to pay to see a consultant privately. But the concept of seeing a private GP was probably my own colleagues up to a certain extent were probably my sort of biggest, I'm not going to call it sort of haters, but certainly it wasn't quite deemed the right thing to do. I get it now and I understand it. Private general practice now is the fastest growing part of general practice, and GPs are totally understanding the concept of what we do in the private sector. By the way, it's no different to what we do in the NHS. Sure, we see some of the easier stuff and access stuff, but every patient that I see in the private sector is one patient that is not being seen in the public sector. If you close the private sector today, the NHS would collapse within hours. It just wouldn't be able to cope with the demand. So, and I truly believe that there's a marriage to be had here. And when I say a marriage to be had, at the moment, it's very disparate, it's very separate. Or if you're going private, some clinicians still feel, well, no, I'm not involved anymore, and they'll kind of pull themselves away in some sort of feeling let down type of demonstration. My true sense is that the private sector is here to stay. If we look at the amount of things that the NHS currently commissions from the private sector, it's nothing short of colossal. It's in the tens of billions. This relationship isn't a new one. The question for me is, how do you start to, and look, when I say innovation, we've done so many different things, integrated digital concepts. We're bringing together GPs, pharmacists, mental health practitioners, diagnostics, community diagnostic centers, neighborhood health centers. One day they will get off the ground. All of these things are happening, and these are all fantastic. But the true element is, how can you start to, and certainly not at the risk of turning into a US system, which is a high cost, high insured environment. I certainly would not want that for the United Kingdom. But I think there is definitely a partnership with the private sector whereby we start to understand that we have one common goal, which is to treat people. You've got to sometimes forget who the payer is for a second and start focusing on, what are we trying to do? We're trying to deliver healthcare. We're trying to improve patient outcomes. We're trying to increase longevity. We're trying to use preventative healthcare. Both of those partnerships working in more of a coherent manner rather than sort of rubbing up against each other.
For healthcare professionals listening who are feeling exactly what you described, exhausted, emotionally depleted, wondering if they can continue, what would you say to them? What options should they know exist?
First thing, I'm going to say you're not alone and you're not weak. I need to clarify that last comment, because literally that's how, at one point in my career, probably 15 odd years ago, I felt shameful. I felt weak. I felt inadequate to even feel these types of emotions. It was all very much self-created, don't get me wrong. But you can understand, as doctors, that's how our genetics are. We're all human, but as doctors, we do put ourselves through slightly different levels of standards in that sense. So you're not weak. And I think burnout is not a character flaw. We need to realize that it's a normal human response to sustained overload. Do not wait until you're broken before you change something. Just to give you that example that I mentioned earlier, that before somebody leaves or does something, it's been going on for years. And my question is, start this early, speak to your colleagues, your occupational health, your own GP, your appraiser, reduce sessions if necessary. That's another difficult thing to do because I have a family at home. I have a mortgage to pay for. I have children to educate and feed. And reducing sessions means, well, my income's going down. So already you can understand you're no different to any other profession. Again, I don't want to make us out to be special, but the reality is that other people can pull out. We don't. And that's where I think some of our own internal clocks need to probably change a little bit. I think ultimately that medicine needs experienced, healthy clinicians for the next 20 years, not broken clinicians for the next 6 months.
Thank you so much for your time. That was really insightful.
No, thank you. It's been wonderful to speak.